us tonight to talk about asthma in spring, allergies and thunderstorms. As Bertha said, I'm Marg. I work for National Asthma Council Australia as the Program Manager for the Asthma Best Practice Program, which brings education to health professionals around Australia. And I also work as an asthma educator in a private general practice here in Melbourne. So I'll go through the session tonight. As Bertha said, there will be opportunities for questions during the presentation and again at the end. So these are the learning objectives for tonight, but what's more important for me is that you get out of tonight's presentation what you need to know. So as I said, please ask those burning questions. But we're going to talk about the association between allergic rhinitis and asthma and just summarise the treatment guidelines for allergic rhinitis. If you've been on some of our other NAC webinars, we've covered asthma pretty thoroughly in those. And then we're going to talk specifically about thunderstorm asthma, which is a rather unique condition, and the guidelines of management for those, and talking about written asthma action plans and asthma first aid in relation to thunderstorm asthma as well. So I'd just like to bring your attention to the Australian Asthma Handbook. It is a completely online resource, and this is the web page. This is what it looks like if you go to that web address there. It's a really interactive website. From here, you can actually go to the NAC's website, the handbook website, or the Sensitive Choice website, where we've got some consumer resources. But these tabs along the top here drop down and give you all the information you'll need about managing asthma. It's also got a really good search function here. So if there's just something you want to know, type it into the search function and it'll take you there. So please familiarise yourselves with it. As I said, it's freely available online. You can put it on your desktop or have it wherever you need it to be, that you can quickly check any questions you might have about managing asthma within Australia. So let's talk about allergic rhinitis, or hay fever as the community would call it. It's a really common condition in Australia. About 15% of Australians have allergic rhinitis, and it's really one of those conditions, a little bit like asthma, which can be underdiagnosed. Allergic rhinitis can certainly be undertreated or suboptimally self-treated. So, you know, we've spoken about this in asthma, and we understand it in asthma for years, that it's really always surprises me how tolerant people are of their symptoms, or they just become very complacent about those symptoms where they don't even recognise them necessarily as something that's not quite right. In asthma, of course, that's the shortness of breath and the wheeze and the cough and the chest tightness. But in allergic rhinitis, people will just put up with those itchy eyes, bit of a runny nose, bit of a constant sore throat, or the throat clearing, and they often don't treat it really well. But they really do need to, particularly in springtime and particularly if they have asthma. Allergic rhinitis is most common in those between 15 and 54 years old, but generally can affect anyone in the population. And many people are sensitised to multiple allergens, which means it can be much more difficult to treat, or not. It's not that it's more difficult to treat, it's that it's a constant treatment, I should say. So some people do just get it in springtime, for example, but some people have allergic rhinitis all year round, and those are the ones that sometimes have multiple allergens going on. We talk about the United Airways disease, and you may have heard that term, but really it's talking about allergic rhinitis and asthma in the same person, where we've got upper respiratory airway inflammation, which is the upper airways, the nose, the sinuses, the back of the throat, and then the lower inflammatory processes, which is the smaller airways of the lungs. And in this situation, you really need to understand that it's the same inflammatory process wherever that's occurring in the airway system, and we need to be treating both conditions, as I've said. So just some data there, 50 to 80% of those with asthma also have allergic rhinitis, and about 20 to 30% of those with allergic rhinitis have asthma. Allergic rhinitis is also an independent risk factor for asthma in children and adults, so it's worth asking those questions when you're examining someone for asthma. Do you have any allergies? Do you have allergic rhinitis? The presence of both of these conditions is often associated with worse asthma control, and that means there's an increased risk of a severe asthma flare-up. And that's why it's really important in thunderstorm season to be treating both these conditions as well. So we need to assess for allergic rhinitis, as I said, and the common symptoms are these itchy, watery eyes, excuse me, rhinorrhea or runny nose, sneezing, constant throat clearing, cough, frequent sore throats, might be snorers, might be mouth breathers, might have a lot of dry mouth. There's an allergic rhinitis brochure that NAC put out, and in that brochure there's a list of the symptoms, and when you look at those symptoms it's really interesting because it's not just the ones that we actually are really aware of, so it's worth asking the questions of folk. We need to find out the frequency of the symptoms, so whether it's seasonal or perennial. So seasonal symptoms, of course, happen at certain times of the year, and spring is the most common one. And usually those triggers are around grass seeds, pollens, perhaps different weeds or plants like wattles, for example. Perennial rhinitis is non-seasonal, so that's there all the time, year-round, and sometimes those triggers are related to, say, dust mites or molds or pet dander, for example. So people that are allergic to cats or dogs or horses are the really common ones. They may have allergic rhinitis whenever they're in contact with those animals. We need to ask people the impact of their symptoms on their day-to-day function. So if symptoms are relatively mild, even if they're occurring fairly frequently, the impact may not be too bad. So if people have just got a bit of an itchy throat or watery eyes, for example, they might not feel that that's too severe and it may not impact them too much. But if the symptoms are more severe, so it's affecting their sleep or affecting their functionality in any way, then that really needs to be assessed and treated correctly. It can be quite life-changing for people to get that under control. There may be identifiable triggers, as I've talked about, and that's part of history taking. So asking about when do these symptoms occur? Do you know of any triggers? Or you might be able to just sort of work out what triggers could be likely, depending on where people are living and what's in season at that time of year. And then we will do a physical assessment, so inspecting the upper airway, looking for the swollen turbinates, that nasal inflammation, that transverse nasal crease, which is this diagram from the constant sort of nose wiping. They'll get these creases across the bridge of their nose. Looking for mouth breathing or reduced nasal airflow. Often people with hay fever have those dark sort of circles, quite baggy eyes, if you like to think of it like that, puffy, swollen eyes, dark circles under the eyes. They may have sinus pain or sinus congestion. And we'd also think about asking about other coexistent allergic type conditions such as asthma and eczema. Through the presentation, there are some resources on the slides there for you, but there is a resource list that you'll get with the evaluations at the end. The other things we can do for allergic rhinitis, of course, is do some diagnostic investigations. So skin prick allergy test can be done in some general practices, but often is done through an allergy specialist. So this is where the allergen is actually placed onto the skin, usually on the forearm in adults or perhaps on the back for children, and then there's a little scratch put through so that some of that allergen is actually into the system of that person. And you can see from the diagram there that you get this flaring response, and you measure that response, and then that gives you a classification of the type of allergy, whether it's mild allergy or moderate or more severe allergy. We can also do specific allergy testing, so IgE allergy testing. We need to be quite careful that positive results don't necessarily prove the allergens are causing the symptoms, and an example of this would be for a food allergen, and food allergens may cause some allergic rhinitis symptoms, or they may not. Some food allergies cause gut symptoms, so we just need to be mindful of that. So just looking out for that. FBE, so that will tell us inflammatory markers, but it may not tell us much else. And there's some unproven testing methods, so things like kinesiology, reflexology, these types of things. I think, and I'm sure you probably do the same, that when you're talking to people about their allergies, and if they say to me, oh, I'm allergic to this or I'm allergic to that, I always just gently ask, how was that diagnosed? Is that something they've worked out themselves through elimination, or is that something that they know through a specific test like a skin prick test or an IgE test? It's useful for us to know, because if we're going to be treating people for allergy, we want to know that that's a real and confirmed diagnosis. So the treatment for allergic rhinitis, many and varied, as I'm sure you know if you're in your local pharmacy, you go into the allergy aisle at this time of year and there's just a plethora of medications and devices, some over the counter, some scripted, that you can be using. And choice is great, but choice means that people may not be actually using the recommendation or the recommended treatment at the time. So generally the treatments revolve around the intranasal corticosteroid nasal sprays. They're highly effective and highly recommended for treatment these days. They are corticosteroid based, like many of our inhaled asthma therapies, but they're very topical. So you're literally spraying them onto the epithelial layer in the nose and the sinuses there. And so it's treating that inflammation right there. The intranasal corticosteroid sprays do also help with eye symptoms, and a lot of people don't understand that. So they think, oh, I don't want to use that because I need something for my eyes, so I'll just take an oral antihistamine and that'll treat everything. And oral antihistamines are very useful. They certainly help dry people up, but they don't actually treat inflammation topically where we've got that occurring. So this is where we've come to, got lots of these products. We need to think about what we're actually treating. We can get antihistamine nasal sprays as well. So once again, they will dry the symptoms up. They'll stop the nose running, for example, but they're not treating the inflammatory process. We can get a combination of both of the above, so the intranasal cortico and the antihistamine in a combination nasal spray, and they are scripted here in Australia. We can get the rapid-acting oral antihistamines, and there's a huge number of those available over the counter for people, and it is very safe for people to use both. They can use nasal sprays and take an oral antihistamine if they need to for their symptom control. In mild cases, people may be able to manage with saline sinus rinses, and these can be in nasal spray, or they can actually be, a mixture that people mix up of the salty water and do an actual sinus rinse. For all of the above, the sinus rinse and the nasal sprays, really important, as it is with any of our inhaled medications, that people are using these devices correctly. So on the National Asthma Council website, there's excellent how-to videos which demonstrate the correct use of nasal sprays and also demonstrate correct performance of a saline rinse. So you can have a look at those yourselves, or you can certainly recommend those to patients that you might be looking after. Other ways of managing allergies are to avoid the trigger, and that, as I said, that's really important that we've actually had that as a confirmed allergen before we talk to people about allergen avoidance. And sometimes that's effective and sometimes that's extremely difficult. So you can imagine if you're allergic to dust, for example, or types of pollens, they're in the wind, they're in the air at certain times of the year, and unless you're going to lock yourself indoors, then it's really hard to avoid that. So it might work for some things, it might work for pets, for example. We can have specific allergen immunotherapy, what we call as desensitization, and this is now available in a couple of forms. So it can be sublingual or subcutaneous, which is an injection form. These are not for the faint-hearted. They're longer-term treatments, so usually 3 to 6 months, or 3 to 6 months for about 2 to 3 years. They're available through allergy specialists, and of course, there's costs involved with that. So people need to be very confident that they've had the allergen triggers correctly diagnosed and that this is being managed by a specialist so that they can get some really good results from it. But it's really life-changing for those people where they can actually become desensitized to their triggers. This is the only therapy of all the ones on this slide that actually modifies the allergic immune response for people, which is why it can be so helpful for them. We should be avoiding oral corticosteroids as a treatment for allergic rhinitis, as we should be avoiding it for the treatment of asthma unless it's an acute treatment. There are allergy treatment plans available through the ASCIL website. That's www.allergy.org.au. So those treatment plans would look like this one here on the right, and it's like an asthma action plan, I guess. So it lists out the treatment that you're recommending for this person, medication treatment or other types of treatment that they may be using. Got a little diagram there talking about the correct technique, and it's got spaces there to add in different medications as well. So that might be really helpful for some people. This one here on the left is more a diagnostic table that I took from the Asthma Handbook, just to show you some of the tools that are in there. And this is talking about, you know, the way of managing people. So we'd just be assessing the pattern of their symptoms, and if they're moderate to severe, as I said, we would start with the treatment of the intranasal corticosteroids. We might add in some other therapy and review, and if it's controlled, then that would be maintained, and if it's uncontrolled, we'd go through the steps of reviewing diagnosis, checking adherence and device techniques, considering the allergy testing, until you get down here. If people are, you know, still not responding the way that you would think they should be, then certainly refer to an allergen specialist and really try and get their treatment to be specific for them and effective for them is what we're trying to do. So just having a look at the allergic rhinitis treatments, this is a poster that's available through NAC. Normally we would be able to post you out a nice coloured glossy one that would look like this, but because we're still all working from home here in Melbourne, that's not possible for us to do at the moment. So you can actually download it from the website and have a look at it, or you can just have it on your desktop like this to show people. But it just goes through the categories of the medications that I've been talking about. So the corticosteroid nasal sprays, the different ones, saline spray, the antihistamine sprays, combination sprays, and I think there's another one on the market now, and then other treatments here that we might be able to use. All right, as I said, if people don't respond in the way that we think they should or the way that you would expect with their type of treatment, and you've checked their diagnosis, you've checked their adherence, you've checked their nasal spray device technique, then that might be an opportunity for you to refer them to an allergy specialist. Or if their symptoms are really persistent and severe, so they've had some response, but not, you know, not giving them good relief, then certainly refer on. If they've got poor asthma control, despite the regular preventive therapy and despite their rhinitis treatment, we really need to get that sorted. So they might go to a respiratory specialist in that situation. If there's food or occupational allergies suspected, that needs investigating. If there's other upper airway things going on, such as ear problems or purulent discharge, sinus congestion or disease, they've lost their sense of smell. So we just need to be referring those people on, or if they're a good candidate for the immunotherapy, the desensitization, as I've said. So there's lots of products out there. It's about making sure that we're treating people with the most effective for their symptoms and their level of symptoms, and then it's about deciding how long they need that treatment for, whether that can be seasonal or whether that needs to be all year round, or you know, depending on the severity and the symptoms that they're experiencing. Just take a pause there, Bertha, and see if there's any questions.
Hi, Mark. I do have a couple of questions.
Mm-hmm.
Can
Susan,
children, yes,
wrong name, I beg your pardon.
that's okay. Can children use combination nasal spray?
Oh, that's a really good question. And always when I'm asked this, I think, oh, I should have checked the PBS requirements for that. I'd have to check that. I'm really sorry. I would suggest yes, but it would be on the product information, and I don't know that from the top of my head. I'm sorry.
Okay, the next question. Is there a time limit to use intranasal corticosteroids, or can it be used for years continuously in perennial allergic rhinitis?
Yeah, look, this has been around. This is a question that does pop up every now and then. And I always encourage people that if they're symptomatic, they can safely use the intranasal corticosteroid sprays continuously, as long as they're not getting side effects. So the common side effects can be that they actually get some nasal irritation, or they may experience blood noses, for example. And sometimes that can be solved by checking their device technique. Sometimes it can be solved by asking them to use a salt water spray first, and then gentle blow of the nose, and then applying the corticosteroid nasal spray. But what we need to remember for our corticosteroid nasal sprays and the asthma inhaled corticosteroids are that they are in very low doses. We all think of steroids as the oral steroids, which are much higher in doses. These are in micrograms, and they're usually very well tolerated by people as long as they're using the device correctly. So yes, they can use them continually if their symptoms warrant it, and as long as they're responding to that treatment. The usual regime is that you would start them using it perhaps morning and night for a couple of weeks to really sort of hit that inflammatory process. And then most people can manage their symptoms with one spray each nostril once a day. And some people can even back titrate to one spray every second day, for example. And then, you know, that's a lot more manageable for them. Thank you.
Next question.
Any questions?
Yes, what is the best management for people that have allergies all year round rather than seasonal?
So if they're causing hay fever or allergic rhinitis symptoms, then the recommended treatment would be the intranasal corticosteroid sprays. And then as per that diagnostic chart that I showed you, it may be that seasonally or at other peak times you could add in perhaps an oral antihistamine as well, or something like that. So all those treatment options are available, but generally now the recommendation is to start with the intranasal corticoids, and if they're managed well on that, then they can continue on that.
That's all for now. Thank you.
Okay, thank you. Thanks for those great questions. So we'll move on now to talk about thunderstorm asthma. So these are the definitions of thunderstorm asthma that I found. And I'd just like to point out that the resources that I've used for the presentation on thunderstorm asthma tonight have come from the Epidemic Thunderstorm Asthma paper, which was written by National Asthma Council Australia, and also the State Government of Victoria commissioned a review of a response to the thunderstorm asthma event that occurred in Melbourne in November 2016, and some of the information from this presentation is from that report. So thunderstorm asthma, I'll use the NAC one, of course. It's an unusual cluster of allergic asthma flare-ups, including severe acute asthma, associated with some types of thunderstorms in spring or early summer. So if we think of it like that, it's a rapidly occurring event that's happening usually with specific types of storms in spring or early summer, and usually along southeastern Australia. So this slide I find really interesting for lots of reasons. This is the history of thunderstorm asthma events in Melbourne, and most of us here in Victoria can certainly vividly remember the last one there on the chart, November 21st, 22nd, 2016. This event occurred from 6 p.m. onwards, and there's the data there for you. 3,500 people presented to ED over the next 24 hours, 135 ICU admissions, and 10 deaths directly related to that thunderstorm event. But if we go back up the slide, you can see there that it's not a single phenomenon. This has been recorded in Melbourne since 1984. And very interestingly, all the events are in November, and lots of them in this second half of November from the 21st onwards there. The severity of them and the number of people affected reduced if they were in the evening or overnight, but those that occurred in the daytime, and certainly this one here, really affected extraordinary numbers of people. There's been other reported episodes in Australia, so those listed there, Tamworth, Wagga, Newcastle and Canberra, and some incidents also recorded internationally. The reason these events occur in November is because here in Victoria, that's when the ryegrass is mature, and the ryegrass pollen is thought to be one of the biggest culprits when we're talking about thunderstorm asthma. So just once again, a little bit about the stats there. As I said, 3,500 people presenting to emergency departments or other healthcare services during that 30 hours, which was a huge increase on the 3-year average. So an increase of 672% of presentations, and then over 900% increase on asthma-related admissions into public hospitals in Melbourne. So it was a really overwhelming public health emergency, which really stressed the medical services here to their absolute limit. So both the ambulance services and the emergency departments were really overwhelmed. It was very difficult. And of course, we've learnt from that, and now there's a lot more exposure and information and media about thunderstorm asthma, which is excellent. So it's helping the public to be more prepared. The reason that it's some thunderstorms is because we need this sort of collection of situations to create a thunderstorm asthma event. So it requires a high concentration of allergenic material in the air, and that's usually in Victoria, that's usually ryegrass pollen. But it could also be fungi or dust or other things. It requires a thunderstorm outflow. So these are very windy storms. So the wind brings the pollen up, and then the wind ahead of the storm front brings the pollen back down to ground level. The moisture in the storm ruptures the pollen into tiny little sizes which are more respirable, and then they go right down into the small airways of the lungs. And then it's about the number of people that are actually exposed who are sensitive to the relevant allergen. So this is why it's not all thunderstorms. This is why it's at certain times of the year, and the numbers can relate to the number of people that may be out and about or exposed at that time. This little map at the bottom here, I know that's really hard to see, but it's just indicating the rainfall in the spring season of that November, September to November 2016. And this very high rainfall here that occurred in the Western District of Victoria resulted in a very high grass growth and a lot of ryegrass, and then we got those really high pollen days. And that's very similar to this year, where we've had high spring rainfall down here. So this diagram is giving you a visual representation of the mechanism for thunderstorm asthma. So as I said, we've got a high concentration of pollen, and then the storm updraft, so the wind sweeps that pollen right up high into the moisture-ridden clouds up here, where the pollen ruptures. The moisture affects the pollen and it ruptures into tiny pieces, and then the wind, the downdraft and outflow ahead of that storm front, ahead of the rain, brings that pollen right down to ground level where it can affect people and they can breathe it in. I think that's a really good visual way of thinking about it. So this video, if it works, let's hope it does, just shows you the pollen rupturing. So I'll just get this turned on. So just watching there where the pollen, these are the normal sized pollens, and then they rupture with moisture into these tiny little particles, which then are swept down with that outflow of the storm. You can see that there happening. I actually witnessed this some years ago. I was doing one of the great big bike rides in the Halls Gap Horsham area, and it was early in the morning and riding along, and there was like pockets of sort of like fog or mist, I would have called it at the time. I didn't realise it was pollen. I'd never seen that before. And I called in at the first aid station this morning at the morning break and was speaking to the first aid officers there, and they said, oh, that's actually the pollen in the air. So some of you may have actually seen that as well. I found that really fascinating to see. So who's at risk of thunderstorm asthma? We've got certain groups that are at risk. Certainly anyone that knows they've got a sensitisation to ryegrass pollen needs to be careful, because they will have some sort of response to that very high pollen load. If they have allergic rhinitis with or without known asthma, they are at greater risk of thunderstorm asthma, and that explains itself. They've got the allergy, they may not know they have asthma, they may never have had those pollen granules right down into the small airways of their lungs before, but it certainly can happen. Anyone with asthma, especially if they've got poorly controlled asthma or are not taking their preventer through thunderstorm asthma season, are at greater risk, of course, of the thunderstorm event affecting them. Anyone that's ever had asthma, so there's a certain number of people that had asthma, you know, maybe as a child, may have had no asthma since, but that inflammatory process, as you know, can be re-triggered at any time, so they may be affected by thunderstorm events. People with these allergens that are exposed to the open air before and during a thunderstorm during the pollen season, or people living in or travelling to the high pollen areas, which are historically southeastern Australia, that have allergic rhinitis or asthma, are also at an increased risk. So we've got a bit of work to do, you know, making sure we help these people to get ready for the thunderstorm season. So this is our general advice that we tell people in thunderstorm season, where, you know, anyone that may be at risk that's had asthma, allergic rhinitis, or certainly was affected by previous thunderstorm asthma events, we advise that they avoid outdoor exposure when the pollen count's high and thunderstorms are predicted. And now, as I said, because of the shocking risk, number of people affected and the deaths in 2016, this is advertised and promoted a lot more readily. So we've got Melbourne Pollen Count app in Victoria, and you know, you need to look what your apps are in your state or territory to know what your pollen count is. There's an Aerator app, and there's a Vic Emergency website app, Vic Emergency website. There's also ABC emergency website nationwide. So these places are where people can look and be aware of what's happening and what's actually predicted, because that can really help them to get prepared. If they are at home or in the car during a thunderstorm asthma event, then close the windows, turn the aircon off, or use recirculated air to reduce the amount of exposure to the pollen and certainly to the wind during the thunderstorm, and certainly right ahead of the thunderstorm. If there's any signs of asthma, so we need to really educate people about what to look for, and that's easy enough to do for those that we know have a diagnosis of asthma, but not necessarily to others. So it's a conversation to have for those with allergic rhinitis, for example, in springtime in southeastern Australia. If you happen to experience any signs of asthma, then please do something about it, which for them would be following their asthma first aid. If people have asthma and are on treatment, then they should have an asthma action plan, and so they can be encouraged to follow their asthma action plan. And of course, reminding everyone that if asthma symptoms occur rapidly, then they need to call an ambulance and say they're having an asthma attack and get some help quickly. The poorer outcomes are for those people that delay and wait. So how are we going to manage these people? So if we know that they've got asthma and allergic rhinitis, this is a really excellent time to be proactive in spring. Arrange a review appointment. During COVID, we've still got telehealth item numbers. So if you can't arrange face-to-face review appointments, you may be able to have a telehealth appointment. And this is an opportunity to discuss the increased risk during the springtime thunderstorm season, assess for allergic rhinitis, check the treatment for both, make sure that they're using their devices correctly, make sure we're managing them per the current asthma guidelines. So I'm sure you would know that the asthma handbook was updated this year in September. That was launched, and now even those with mild asthma are recommended to be on preventer therapy, and that's usually inhaled corticosteroid for most people. So now is an opportunity when we're doing our spring reviews to check that people are taking what they're prescribed and that they have access to reliever therapy, of course. As I said, really great opportunity to check device technique and adherence. So saying, you know, are you using your preventive therapy? How often are you using your preventive therapy? Show me how you're using your devices, and, you know, really encouraging people to be doing these well. You can give them device demonstrations, or you can show them the how-to videos, as I talked about earlier. During springtime, or at all times, those with asthma and allergic rhinitis should have access to reliever therapy, particularly those with asthma. So for people with allergic rhinitis who began to experience some asthma symptoms and weren't previously on asthma treatment, that would be short-acting beta-2 agonists, usually Ventolin or Brucanol. For those with asthma, there's choice now of reliever type therapy, so that can be the short-acting beta-2 agonists, or it can be the Symbicort anti-inflammatory reliever, which can now be used as reliever therapy for those groups of people. So encouraging proactive treatment of their allergic rhinitis. Remember, we talked about assessment and diagnosis and the recommended treatment. So springtime in Southern Australia, anyone with allergic rhinitis should be really nailing their treatment, and that's usually the intranasal corticosteroids. If they're only using it seasonally, then they should start it in perhaps September and use it through to the end of the pollen season, perhaps end of December, for example. And then making sure that they've got action plans, and that might be an asthma action plan or might be an allergic rhinitis action plan. And that's talking to them about ensuring that they know what to do if their symptoms get worse and they know how to seek emergency treatment. Those with allergic rhinitis and no asthma, then we would be managing their allergic rhinitis as per their current guidelines, and talked about that earlier in the presentation. If we can, we'd identify those with grass pollen allergy, because that's the real culprit in thunderstorm asthma generally. And as I said, we'd be treating them usually with the intranasal corticosteroid sprays throughout the pollen season. If people are travelling, and I know that with COVID, that's not happening very much at the moment, and we've certainly been very restricted. But if you're not normally in Southern Australia, but you know that you've got to come to them in springtime and you do have allergies, then that's another group of people to be talking about the risks of thunderstorm asthma for them. And as I alluded, if these folk are really familiar with asthma symptoms, then it is an opportunity to talk to them. If you feel wheezy or develop a cough or feel short of breath during this time of year or during a thunderstorm event, then you need to know what to do. You need to know that you can buy reliever therapy, short-acting reliever therapy over the counter, and then making sure they know how to use it properly and know their asthma first aid as well. Those with no seasonal allergic rhinitis and no asthma, we want to just be reassuring this group that their risk is quite low. Certainly in Melbourne, in my asthma clinics in general practice, after that November 2016 event, I was fully booked out for months and months and months, which was a great thing, exhausting but great, because people really wanted to have their asthma assessed. They were really afraid. There was a lot of media coverage of the event and a lot of media coverage about the emergency responses and the numbers of deaths. But it's just one of those reminder times when, you know, it's good that people are aware, but we don't want people panicking. And I think the most positive thing that I could say to people was then learn about asthma first aid so that you can actually help people if you're in that situation where someone's developing symptoms and you're there. If you know about asthma first aid, that can be really life-saving. So part of asthma first aid for those with asthma are asthma action plans. And we know that asthma plans have been around for a really long time. We've got a much better coverage of asthma plans in children because childcare centres and schools require them, but we don't do so well with the adult population. There's still not a strong uptake of written asthma action plans in the adult population. So this is something that all of us can hopefully do something about. Asthma plans improve outcomes because they give people information about what to do. So it lists their symptoms when they're well and their medication that they should be taking when they're well. The changes that indicate to them when they're becoming less well or their asthma is worsening. So those things like increased wheeze, increased cough, breathlessness, especially waking up at night with any of those symptoms. And then it tells them what to do, how to respond, what medications to take and how frequently. And then it's giving them advice about when to see a doctor. So important, as I've said, people tolerate symptoms for way too long. So the plan is about discussing with them when you should see the doctor and then when it's an emergency and when you should be calling an ambulance. So it really, really important information for us to be giving people, making sure that it's individualised to the person in front of them, in front of you, making sure that it's more than just a piece of paper, that it makes sense to them and that it's got information that's useful to them. Community first aid is available for anyone who comes across someone who's, you know, struggling to breathe or having an asthma episode. So this is where it's often called asthma 4x4x4, and you're giving 4 separate puffs of reliever therapy via spacer, 4 breaths per individual puff, and then monitoring for 4 minutes. If they respond and that's helpful to them, then you may only have to do that the once and you can just watch. But if they're not responding and they've still got symptoms after that first 4 minutes, then you repeat. And if the symptoms persist, then you're calling an ambulance and repeating those steps until help arrives. So community first aid, pharmacy first aid, whatever we want to call it. These posters are available through NAC for children and adults, and it does talk about Ventolin and Symbicort on both of these charts. So it's a really great opportunity to be talking about that and educating people about that at the moment. So how are we going to prepare for springtime thunderstorm asthma season? We've talked about what it is. We've talked about the climatic conditions that we need or that will be in place when a thunderstorm is occurring. And just here in Melbourne last week, I think it was, we had a thunderstorm asthma warning day, which was fabulous to see. I saw it on 2 different news channels. I heard it on the radio, it was on the apps. So this is where, you know, the public are much more aware now and much more able to be prepared. And those people may have been able to stay indoors during that event. If not, then at least they know that they need their reliever with them on those days and they need to be aware that it's a high risk day for them. So at your clinic, as I've said, spring's a great time to review people with asthma. And, you know, asthma is one of those conditions that we always like to see people a couple of times a year. And in my clinics, I like to see people when they're well. As their asthma educator, I can't help them during an acute flare-up. That's when they really need their GP. But I can certainly assist them with preparation and education when they're well. So we want to review those with asthma, and we want to especially review those with asthma and allergies, or anyone that was affected with previous thunderstorm asthma events. And we've got the capacity to do this with our medical software. We can use the recall and reminder functions to help us remember to see these people. But at work, in our clinics, at our healthcare providing services, we need to be aware of the high pollen count days and thunderstorm weather forecasts. And as I've said, that's done much more effectively these days. We need to make sure we've got bronchodilators available and that they're in date in case we get a great influx of people coming in. We need to have a supply of spaces so that we can adequately administer medications to people should we need to do so. It's also an opportunity to have a think about your clinic policy for people that present with asthma symptoms. So do the medical receptionists know what to do? Who's responsible for triage? Who's responsible for checking the bronchodilators and the spaces supply? All of the types of things that we would need to be prepared for an influx of people with asthma symptoms. It's an opportunity to train all staff in asthma first aid and to have a first aid chart on display. And, you know, it's interesting when you do sit in waiting rooms what you read. And I was recently in a waiting room with my elderly dad, and unfortunately we were there about an hour and a half, but I think I read all the posters that were around in that waiting room. And, you know, and I'm educated in this type of thing, but if it's in front of you, people will look at it. So it's a good opportunity to put these charts up, especially during spring. As I've said, you may be able to use telehealth for COVID reviews. For people who don't have access to an asthma educator in your practice or in your area, Asthma Australia have an excellent program called the Coach program. It's a 1-800 free call number where patients can dial in, and an asthma educator will answer that call, and the community can ask them their questions, and GPs can refer patients to use the Coach program if they can't provide the education themselves, or if that person needs to be making these calls at different times of day. So just handy for you to know. Have a look on the Asthma Australia website for more information on the Coach program. In your pharmacy, then also really great opportunity to check the supply of asthma medications, particularly the reliever therapies, the supply of the spaces. Good idea to have a group discussion about patients presenting with asthma flare-ups or symptoms, because people will certainly go to pharmacists to talk about their conditions and seek advice, which is a fantastic thing. There is a flow chart available, a pharmacy flow chart available, which talks about symptoms that people may present with and what you may be recommending on the NAC website. So it's an opportunity to have that discussion and make sure everyone knows their responsibilities and how to prioritise or how to manage anyone that does present with symptoms. Once again, training everyone in asthma first aid and have a chart on display if that's possible, but know which GP clinics are open after hours, know where you can refer people to seek assistance if that's what they need to be doing. And then all of those people that are requesting hay fever medications, it might be an opportunity to speak to them about asthma symptoms. And depending what it is that they're using for their hay fever, then, there's a whole nother conversation about the recommended treatments for allergic rhinitis and asthma, if that's part of what's going on for that person. So just other thoughts to consider. Does your workplace clinic have an emergency asthma plan policy? Is this a good thing that you could do? Who has responsibility for different aspects of care? Is there a consistent approach to emergency asthma management? Does everyone know where the reliever is, for example? Does everyone know how to manage someone that's coming in with acute symptoms? And there's some really handy resources available for you in the asthma handbook. So I'd recommend you have a look there in the acute asthma section. And just touching on asthma and COVID, because COVID's ruled our lives now for almost 12 months and is going to continue to do so for an unknown amount of time. There is a section in the handbook on COVID, and there's also links through the NAC website to the AAH for the COVID. But the recommendations are basically that to check everyone with asthma has a current written asthma action plan. We can use telehealth appointments if need be to make sure this happens, because there's no research has told us that there's people with asthma are at no greater risk of acquiring COVID-19, but people with asthma have respiratory conditions, so the anxiety levels can be higher. So it's a really good time to be checking that their treatment regime is correct and current, adhering to the guidelines, and that they've got a written asthma action plan. I've got to avoid performing spirometry unless urgent there, and there's just that's a moving parameter. So just recently, Thoracic Society of Australia and New Zealand, TSANZ, put out a notification saying that a spirometry can be performed across Australia now, but there are some recommendations for infection control guidelines, and NAC has recently released some spirometry infection control recommendations as well, and you will be emailed that link to that document after the presentation tonight as well. I would just say to you, if you were considering performing spirometry, to just ensure that it's actually required for the patient at this point in time for perhaps diagnosis or management. It's not a time to be performing unnecessary spirometry tests, of course, during COVID, and just make sure you're adhering to your PPE and infection control recommendations in your state or territory. Getting back to our COVID and asthma recommendations, we always advise people to continue with their current asthma medications, of course, including their inhaled corticosteroid therapy during this time. We'd only be using oral steroids for acute severe flare-ups as indicated. An excellent time to really push home that message that we want to avoid using nebulizers. We don't recommend nebulizers for routine home management for people unless there's no other way of administering their medications. But during COVID, it's a really good time to remind people that a spacer and puffer is preferred, and for children, a well-fitting mask and spacer is preferred. Always advising everyone not to share medications and spacers, even between family members, and that hasn't really changed. But we really would need to consider how we'd manage a really dramatic thunderstorm asthma event and still maintain all of our COVID PPE and infection control requirements. I think it would be a really quite stressful situation for all of us. So that brings me to the end of the presentation tonight. Just remembering that these resources are available to you for free on the websites I've listed there, and there's a lot of resources around allergic rhinitis, of course around asthma, but around thunderstorm asthma in particular. And please also just a reminder that you will be emailed a evaluation survey link after the presentation. If you could please complete that, we would be very, very grateful. I certainly go through all the evaluations, and we're working hard to make sure that our education is relevant to you. So that's the end of my presentation tonight. Susan, I'll just check in if there's any more questions.
We have a couple of questions, so if anyone else would like to put a question through, now's the time. While we're waiting for extra questions, I'll start with, what cohort are the most vulnerable to thunderstorm asthma?
So those with poorly controlled asthma are very vulnerable. So people that think they're okay, may not have any symptoms, gotten a little bit slack with their preventive therapy, maybe have stopped taking it altogether. They are a very high risk group for thunderstorm asthma, and those with allergic rhinitis and asthma as concurrent conditions are at greater risk as well.
Okay, the next question, how do we help educate those at risk of thunderstorm asthma?
So I guess it's about knowing about it ourselves and making sure that we identify these people at risk. So, we may be aware in our practices who might be a little bit slack with their asthma management, for example, and that might be a time to get those people back in for a review, as I've said. But it's about education, I feel. It's about just making sure we've got posters up about thunderstorm asthma, that we're doing reviews for those people with asthma and allergic rhinitis. We're checking device techniques so that we know that people are getting the medications we think they're getting. And we're updating asthma action plans and having that conversation with people about recognising symptoms, not ignoring symptoms, and then treating the symptoms correctly and adequately, seeking medical advice as soon as they feel that their symptoms are less well controlled, or when their action plan indicates that their symptoms require them to seek medical advice.
Another different question, Marg, is someone in the audience has asked, and I'm sure everyone is interested, can they have a copy of the PowerPoint presentation as a PDF?
Yes, they can. I can't remember now if we've discussed that between ourselves, Susan, but yes, we can arrange for a PDF presentation. Yeah.
Wonderful. The next question, how long after the asthma thunderstorm has passed are people still susceptible to attacks?
Oh, that's a really good question. So it's actually before the storm comes through. If you think of that diagram of the wind bringing the pollen right down ahead of the storm front, it's actually in the winds ahead of the actual storm that brings the pollen right down to the ground. But in that most recent event of 2016, it was about 30 hours after the storm that the peak of presentations had actually eased off to what would be a normal number of people coming in at that time of year with asthma presentations. So that initial through to about 24, 30 hours afterwards, it seemed to be the time. Remembering that some people perhaps could have had quite mild symptoms initially, and then as their inflammatory response escalates up, then they can develop increasing or escalating symptoms as time goes on.
Okay, the last question I have at the moment, so if anyone has any other questions, now is your last chance. Is nebulizer use appropriate in the current COVID situation?
Well, as I said on the COVID slide, we don't recommend nebulized therapy for people generally if they're well controlled and able to use a device. So for home use, we would normally be recommending devices, whether that's a dry powder device or an MDI and spacer. For people, we would only recommend nebulized therapy at home if there was absolutely no other way of administering medication effectively for that particular person. And I'm thinking, you know, perhaps someone with dementia, for example, or someone with disabilities that would preclude them from using a handheld device, for example. Nebulized therapy can be used in acute asthma therapy, so severe or life-threatening acute asthma. Nebulized therapy may be recommended, and during COVID, though, we would be really needing to, before you use nebulized therapy, to have made sure that you'd COVID screened that person and that they were afebrile and that they hadn't been in contact with anyone with COVID, etc., etc. So your first line of treatment would always be MDI and spacer, if at all possible. I hope that answers the question.
Okay, thank you. So I think that brings us to the end. We have no more questions here. So I'd like to thank you very much, Marg, tonight for presenting. And I'd like to thank everyone for attending and staying through to the end. And we'll see you all next time. Good night.
Thank you. And please complete the evaluations.